here at Deuk Spine Institute. All right, we're going to be doing a Deuk laser disc repair. Is that you pulsing?
Yes, sir.
We've already started here. We have our patient laying down. We're doing a lumbar today. That's the lower back. And she's having lower back pain and left leg pain. Shot? So right now I'm trying to access the disc at L5S1. Our patient, as always, is awake. Shot? Shot? She's awake for the very beginning. Shot? Are you comfortable?
You doing okay now?
She said yes. Shot? So we use the X-ray view, which is the view you're seeing on your screen right now, in spine surgery quite often. Shot? Pretty much every single spine surgery we do as spine surgeons, we use X-ray. And X-ray allows us, so you're way too far out. I want you magged in a little bit. That should be centered up. X-ray allows us to go to the right place in the spine because we use the bones to navigate. The bones are fixed, hard structures that don't really change or move. And what we're fixing usually with spine surgery is a problem between the bones, a disc problem. Let me know if you feel any pain or discomfort. Shot? AP. So if you're looking at the X-ray lateral view with me, you can see the needle coming in from the left side, which is her back, and we're going in for the L5S1 disc space. This patient has 3 herniated discs, L34, L45, L5S1, perfect. You see there's a little bit of curvature to the spine, some scoliosis, it's degenerative type, but we're not here to fix the scoliosis. The scoliosis is not causing her back pain. What's causing her back pain is her disc herniations. And what's causing her leg pain is the disc herniation. Well, when I say disc herniation, to be specific for those of you who have listened for a while, it's not the disc herniation per se that's causing the back pain. It's the annular tear in the disc, which is part of the whole problem. Okay? So to get a disc herniation, first you have to have a tear in the outer wall of the disc. So if you think about, there was an old gum we used to chew when we were kids. It was called Freshen Up. Freshen Up gum. I don't think they make it anymore, but they may. Anyway, Freshen Up gum is interesting because it had a liquid gel in the center, but it had a very kind of tough, chewy outside. So you'd have to bite into it to squeeze the gel out. The gel would squeeze out through any kind of tear in the outer part. And the disc is the same way. You have to have a tear in the outer part called the annulus fibrosus. It's very tough. You have to have a tear in the annulus fibrosus before you get the jelly coming out, before you get a herniation. So everybody with a disc herniation has a tear first in the annulus fibrosus. And for some reason there seems to be confusion about this fact, even today in the year 2019. Scientists don't agree on this whole concept, this whole premise, but it's absolutely true. I've seen it thousands and thousands and thousands of times. And the people who don't see it are the ones who are trying to convince those of you who do see it that it's something else happening. Shot. All right, so you see those end plates? The pedicles look perfect, by the way. But the end plates, we need a little bit better job. Shot? No, that's worse. For sure. Is she awake or asleep?
Are you okay?
Don't pick your head up. Are you all right?
You okay?
You seem to be comfortable. We just want to make sure. That's all. All right. Well, let's see where we are. Shot. Should be getting close. Shot. Shot. It's a little too high. Shot. Now this patient has really nice wide neuroforamen. Shot. It's so nice that she's able to sleep during the surgery, even though we've given her no sedation, right? As of yet. So she's very comfortable, which is exactly what we want for our patients. Shot. But we don't want her completely asleep. I need her help for the first part of the surgery. Shot. So to be able to do the Deuk laser disc repair, endoscopic repair of the disc, shot, I need to first access the disc space. And I have to do that through what's called the transforaminal approach. Shot. Means I have to go through a normal opening in the spine. Shot. And that opening is the neuroforamen. And it's really hard to understand it with that lateral view of the x-ray, but if you look at the tip of the needle that I'm about to put in, there's kind of a lighter area that represents a space, not with bone. And that lighter area, that hole, is a neuroforamen. And I can tell you, she has really nice neuroforamen. Like, they're not collapsed down at all. So why does she have leg symptoms? Anybody? Anybody in the audience know why a patient with a herniated disc would have leg symptoms? Shot. Without narrowing of the neuroforamen or with minimal narrowing of the neuroforamen? AP. The reason that she's having leg symptoms without stenosis by the disc herniation or by spondylosis or collapse, without foraminal narrowing, how could somebody have leg symptoms from a herniated disc? The answer is simple. And it actually accounts for 90% of patients that have leg symptoms from a herniated disc. And it is that the real reason they're having leg symptoms is inflammation of the nerve root rather than compression of the nerve root. There are two things that can cause leg symptoms from a herniated disc in the foramen or in the lateral recess. One is compression of the nerve root, which is what for 100 years neurosurgeons have been taught to treat. Herniated discs that are pushing on the nerve roots. Now I am feeling a herniation here. That's funny because you don't really see it on the MRI that well. But with the patient laying down on her belly, yeah, the MRI doesn't really show a herniation right where I'm at with the needle. Okay? But you can see the needle tip where it is on the x-ray, right there, that's where the herniation starts. I can feel the herniation with the needle tip. So it's bulging out. And as a matter of fact, on the x-ray, you can see it. You can see a shadow, like a bubble gum sticking out there. So it's quite remarkable. That's not seen on the MRI. Why? Why? Because an MRI is done with the patient laying on their back. Right now, our patient's laying on her belly. So she's actually in extension. And when you're in extension, your herniations bulge out more and push. So there actually is a compression component with this disc that we didn't appreciate on the MRI because it wasn't there on the MRI, but it's there in everyday life when she's extending her back. And this is very common for patients. All right, let's get up to the L3-4. So the key point, though, I want to make is I have seen thousands and thousands and treated thousands and thousands of patients successfully with herniated discs that don't push on the nerves. So that flies absolutely in the face of what we've been taught as dogma in neurosurgery, which is decompression. You decompress. You basically treat a herniated disc by removing the herniation and unpinching the nerve root or spinal cord. And that will relieve the patient's symptoms. But that's not true. The truth is that patient symptoms come from inflammation, not compression, 90 to 95% of the time. And I see people with radicular symptoms that have no compression of the root. And when you do the laser surgery on their and repair their annular tear, the inflammation goes away, and so does their leg symptoms. It's quite remarkable. And I mean leg symptoms like weakness, too. Like, how do you explain inflammation of the nerve root causing weakness? Somehow it does. It causes a dysfunction of the nerve roots, like, transmission of electrical signals, basically. That's the only explanation I can come up with. But it's absolutely true. So patients can have sensory abnormalities, tingling, numbness, pain, and they can also have motor abnormalities of the nerve root from inflammation, not compression. Very important to know. It's probably one of the most important things I'll teach you. Why? Because if your goal is to help heal people, heal their pain, you have to understand that concept. I can't tell you how many thousands of patients have come to me, turned away by their doctors, saying, you only have a small bulge. There's nothing that needs surgery. There's nothing that needs treatment. There's nothing we can do to help you at all. Just go learn to live with it, Sean. Well, I can't even imagine being told to live with horrible daily pain. That would be really unfair for a doctor to say that to a patient, but it happens all the time. And the reason is the doctors don't believe that there's anything wrong, Sean. They're brought up to believe dogmatically that the only way a patient can have a problem from a herniated disc is through compression. And it's absolutely not true. And I can't believe that I'm the first person to know this. I'm sure other doctors know this. I'm sure that this knowledge is out there. It just hasn't been shared. So that's why we share it. Interesting. There may be another herniation right here. Are you awake? All right. I got some good news for you. I was able to access all three of the discs with one incision. So you're only going to have one tiny little incision on your back, 7 millimeters, and all three discs fixed with a 7 millimeter incision. That's pretty incredible. There's no other surgery in the world today that can do this. All the other surgeons would make big incisions to get all three discs treated. Okay. Is she comfortable? Can you feel my hand?
Can you feel his hand? Don't put your hand. Feel his hand touching your back. Okay.
Are you with it? Are you comfortable? All right. Well, I'm going to do the discogram, so she may respond. How much fentanyl does she get? Okay.
Tell us if you feel any pain. You doing okay? Anything bothering you down there on your back?
She's a little, it's okay. There's nothing you did wrong. I told you to give her a little more, so we're fine. But once I access it, and everyone's different, she was pretty easy, to be honest with you. We got lucky with her, but a lot of times I'm struggling to get in. But once I get in to the 3 discs, then I'm going to do a discogram. How long does the fentanyl last anyway? Like 20 minutes, 15 minutes? Less? Longer than that? Oh. Yeah, she definitely feels that. Is that your typical pain?
Does that cause the pain that you normally get?
How bad was that on a scale of 1 to 10? So when you have them in pre-op, make sure you talk to them. They're going to get a discogram done, and I'm going to want to know what their pain score is.
I did.
You did?
Yes.
Nice job. That's awesome.
She does have a little.
Yeah, I know. All right, so that's 2 discograms, and we need to do the discograms anyway because we're staining the degenerated disc with this blue dye. I can see she's responding. Her back is tensing up. So, and you can see there's tears. Go ahead, at each level. So if you look at the tears, that's the black dye leaking backwards towards the needle, where the needle's coming from. Let me have the, okay, never mind, I got it. That's the black dye leaking out through a tear in the annulus. That's where the herniation came out. So I've seen thousands of these done, either by myself or Dr. Patel or other doctors. And the herniation always comes out through the annular tear. And the annular tear is always in the middle of the annulus, pretty much. I mean, it can be a little higher, a little bit lower, but it's always going to be in the middle of the annulus. It's not where the annulus attaches to the end plate. And there were some scientists who published a paper a few years ago, maybe 4, 5, 6 years ago, where they said that the herniation comes out where the annulus detaches from the end plate, which is nonsense, complete nonsense. It must have taken them years to get those CT images that they used for their paper, because that's not what happens. The annular tear really happens in the middle of the annulus. Even in trauma, car accidents, falls, normal wear and tear activities, the annular tear is almost always in the middle of the annulus. I've never seen it up against the end plate. I mean, I've seen it once, I think, in 1,000 cases, but it's extremely rare. So, most important point, annular tear is the source of back pain or neck pain if it's a cervical herniation. And the annular tear must be debrided to get rid of their back pain. And that's what the Deuk laser disc repair is, the only surgery in the world that debrides the annular tear. This is the year 2019. I've been doing this surgery for 13 years. And for 13 years, it's been the only surgery. Oh yeah, she needs to go to sleep. I should have told you, but look, once we're done with the discogram, that's 99 time. Can you count from 1 to 100 out loud? Yeah. I mean, I know you haven't done a lot of these with me, but once you do a lot, you realize I do the same thing every single time. So get used to my sequence, and that way I don't have to stop talking to my audience. But once I get those, once I do the discogram, as soon as I'm done with the last one, we're gonna put the patient to sleep. All right. So at this point, we have the 3 needles in, and I've taken 1 needle out, replaced it with a guide wire. The guide wire guides the dilator, which is what I'm actually using to get into the disc space shot at L5S1. So the dilator is what creates the path or trajectory for the tube. This is a tubular retractor. Can you see this here, Sean?
Yes, we can.
So the whole surgery will be done through this tube. Okay, this is all FDA approved stuff. And the outer diameter of this tube is 7 millimeters. So that's why the incision can be so small, because I do the entire surgery through this tube. Again, this is a Deuk laser disc repair. It's been peer reviewed and published since 2012. I've been doing these surgeries since 2000 and I want to say I think it was 6 or 8. I can't remember what year we started. It was a while ago. I think it was 2006, as a matter of fact, when I started doing these surgeries. So, yeah, it makes it 13 years. Almost 14 years now. In 14 years of doing 1,000 of these surgeries, 0 complications to date. Obviously, that's because I have great anesthesia. And as I was doing that, I want you to note that the dilator moved in a little bit, so we're going to back it out, shot. You certainly don't want to put the dilator through the anterior annulus. Watched a pretty good movie, Interstellar. Anybody see that?
Oh, that's a good movie.
Matthew McConaughey, right? Shot? Huh?
Good Matthew McConaughey.
Oh yeah, there's a lot of good actors in there. Actually, what's his name is in there? Marky Mark? You know Marky Mark? The Bourne Identity? He played the bad guy. Hope I didn't ruin it for anybody, but I think the movie's been out for what, a couple of years now? Yeah. All right. So, again, I'm Dr. Arjun Majan, CEO and founder of Deuk Spine Institute. We are doing a lumbar Deuk laser disc repair on a patient with 3 herniated discs, L34, L45, L5S1. And laid still. She doing okay? Yeah, so, you know, she wasn't moving a lot to begin with, so I would say you could probably run her lighter. You know, I think she was pretty well behaved. Okay, so we're inside the disc. You can see the blue dye. Are you okay with her?
Yeah, I'm just checking, and I'm not, yeah.
I just gotta position her manually so I can make a pretty flower.
Do you need me to stop or anything? All right. Good. Yeah. I would say the most stimulating part is done for this disc until I start pulling the cannula back. But she's been well behaved. Very well behaved. All right, so off to the right there at 3 o'clock is the end plate of S1, and the annular tear is just off to the left there. And what happens with an annular tear is you get this inflammation in the annulus. Thanks. And the inflammation is what causes the back pain or neck pain. I get people asking me, do you do this surgery for thoracic herniations? The answer is no, we don't. Number one, it's just too dangerous to do thoracic, I think, at this time, given the equipment we have and the circumstances in which we operate, outpatient. Thoracic herniations would really require taking off the rib head to access the disc through a transforaminal approach. Taking off the rib head it's an endeavor. It's not impossible to do. It's certainly possible, and I certainly could do it. But the truth of the matter is, to be honest with you, you know how many symptomatic thoracic disc herniations I've seen? I mean, all I treat day in and day out are herniated discs. And symptomatic thoracic disc herniations are, in 1,000 patients with back pain, you'll get one that has a painful thoracic disc. Because the majority of thoracic pain doesn't come from a herniated disc, even though there's a herniated disc there. It actually comes from the facet joints, and fractures of the thoracic spine are more common as well than a symptomatic disc. How's she doing? She coming up? I understand. That's why I'm saying keep her. I'm okay with her being lighter. She can even move around a little bit for me. It doesn't matter, as long as they're not coming off the table. And she, you know, even when I was working with her earlier, she wasn't coming off. Laser standby, wipe. Back on. Any questions from our audience, Sean? Watch the fiber. All right, let's get some music on. Who has control of the music for the OR? What do you have? XM radio? You have iPhone? XM? I really don't like the XM options. I thought we were getting rid of XM. I guess classic rock. What do you have over there? Which should be one of the channels. I would prefer my phone because I have Pandora. Sean, why don't you find out from Sonny what we need to do to play my Pandora for the next case?
All right, will do.
All right, for those of you watching the surgery, I'll just commentate. We do these live so you can ask questions while I'm doing the surgery. You can ask me, like, what's that? Why do you do that? You can ask me about socioeconomic issues in healthcare. You can ask me about insurance, and you can ask me about spinal procedures and diagnostic tests. We get a lot of really good questions from our groups over the years. Some of them come up and over again, but that's okay. It's good to hear some things multiple times. I am a little bit tired today, so I'm not going to just talk like I normally do about all the problems in healthcare, unless you want me to. But I'm happy to answer questions, and we do this stream live. This is a live surgery you're watching if you're not watching the recorded version of the live surgery, but we don't edit these surgeries at all. They're literally taken straight out of the operating room in real time, high definition. You're looking through the endoscope with me. You're seeing the laser fiber working on the herniation and the annular tear. The annular tear is right here where I'm at. It's at 12 o'clock. And I'm using this straight firing Homium YAG laser at 30 watts, right? And I'm vaporizing this tear. Look at the tear right there. You see that? So the white is the annulus on both sides of the tear, and the blue line represents the tear. That's where the dye leaked out through that tear. I know it's kind of hard to understand three-dimensionally, but that is the tear, and that's what we're vaporizing away. We're basically cleaning out the tear. And what will happen is the body will heal what I've removed. Okay? If I cut your skin right now, your body will heal that cut over time, as long as you don't have an impediment to healing, right? Like poor nutrition, tobacco use, diabetes, you know, problems with your inflammatory system or immune system. But you can see the tear. It's the blue line. Right here is the tear. And all that golden color stuff is calcium, calcification of the tear. And the reason why the tear calcifies is your body responds automatically, naturally to chronic inflammation by laying down calcium deposits. It's called dystrophic calcification. And anytime the body has abnormal tissue, diseased tissue, you can lay down calcium in a process called dystrophic calcification. And so that's why we're getting that golden color. How are we doing? Everything good? You're happy? She's not moving at all, so we're good. You can keep her light. How's her blood pressure? Good? Perfect. Yeah. We disabled. Why? Okay. I don't have my phone licensing. No. I think we canceled the subscription because we really weren't using it. Yeah, I think the phone's better anyway. I mean, the old days, everybody had to use XM because they didn't have Pandora or anything else. So do we have any source of music? What phone do you have? I don't understand. So, hey, Sean, I want you to have Sonny come in here after the surgery and figure out how to hook up my iPhone.
Yes, we have a workaround for it. He's going to set it up.
Yeah. So that we can play some music. Otherwise, I got to listen to Luis breathing heavily the whole day. Panting in my ears, whispering sweet nothings. Okay, so we're just about done with the L5S1. You can see the epidural space, the epidural fat. This is a calcium. This is a bone spur right here, for those of you wondering. That gold thing right there was a bone spur. I zapped the heck out of it. So there are people who say, oh, lasers don't work on spine problems because they don't cut bone spurs. Baloney. They cut through metal. They're lying to you. There's a lot of people out there that make false statements. And they do it because they have secondary gain. Right? They have something to gain from making a false statement. And they know it's false. But, and if they don't know it's false, they should be more responsible. People should verify facts before they state opinion as facts to somebody who's trying to learn and trying to, especially someone in pain who wants to get better. But this is the end of the tear right here at L5S1. And I'm going to be coming out in just a minute, and then we're going to move to the next disc. We're going to do the same thing at the next disc. We're going to basically vaporize the annular tear, get rid of all that grungy material, that inflammatory tissue, so that this can now heal. The whole concept of debridement is something I learned in my training and residency at the University of Florida in Gainesville and at USC in Los Angeles. I never understood the first time I saw a debridement, like why would the surgeon be cutting out all this tissue out of the human body? Like what's wrong with the tissue? Like I could understand taking a tumor out. I could understand taking cancer out, but I couldn't understand why you would take other tissue out. I just remember as a medical student seeing that for the first time and not really understanding why would it was an orthopedic surgeon. Why would you do a debridement? What are you doing? What are you debriding? And what you're debriding is basically bad tissue. Inflammatory tissue that's been going on. A lot of scar tissue, inflammatory tissue, bone spurs. Kind of just chronic inflammatory junk that causes pain and irritates things. So, yeah, that's what a debridement is. I also saw it in treating wounds that wouldn't heal. If you have a patient who has a surgical wound or a traumatic injury to the skin or their body, and because of circumstances, whatever it is, foreign body or problems with healing, they just wouldn't heal properly. And they would get this tissue that was just necrotic or devitalized, without blood supply, and it wouldn't heal. The skin wouldn't close, their tissues wouldn't heal together, they just pop open. Usually diabetics. And so you have to do what's called a debridement. And we go in there and we clean the edges of the tissue. And that was one of the first surgeries I ever did in my life as a resident, as an intern, was debridement in plastic surgery. I was on the plastic surgery service in Gainesville, Florida, at UF. Dr. Caffey, what a great man. Very compassionate plastic surgeon. He was the chairman of the department. And he taught me about debridement. Anyway, the first surgery I ever did ended up being the surgery that I do every day. But I never could have guessed that I would be doing it as my career.
Yes.
But he taught me something that I'll never forget, and I applied it to the disc. And lo and behold, it's the same concept. Whether you're debriding skin and subcutaneous tissues that won't heal, or you're debriding an annular tear that won't heal, it's the same thing. Both of them cause inflammation. Both of them cause a buildup of tissue, scar tissue, abnormal tissue. Both of them cause pain and suffering. So that's what the Deuk laser disc repair really is. It's a debridement of the disc herniation. And it's not done in any other surgery. And that's why Deuk laser disc repair has the highest success rate for curing back and neck pain, 95% average, because we're addressing the source of the pain. It's pretty remarkable as I reflect back on the history of this surgery. And these patients take, they don't end up getting fusions because I fix their problem endoscopically. All right, that's the disc tear. Let me just check, let me just verify. Yeah, that's the epidural space up there. You see the fat, the golden fat, and a little bit of epidural veins. And the nerve, the left L5 nerve root will be right there. Now let me just make sure. I may want to take some of these little pieces out. Let me have the laser. Now these really aren't pushing on the nerve, but they're just next to it. And I don't want to take any chances and leave anything behind that we should. Yeah, I just take 2 seconds here. Now because the nerve is kind of exposed, I have to be super careful not to get it. I'm literally working just underneath it. Thank God I know what I'm doing. Huh, Luis?
Yes, sir.
Believe it or not, there's a lot of surgeons that get in and they have no clue what they're doing because they didn't pay attention in medical school or They didn't do their training well. Everyone thinks that surgeons are all trained the same, but we're not. Not even close. That's the biggest mistake or myth you could ever make. Just like anesthesiologists are not all the same, surgeons are not all the same. Some of us are really, really good at what we do, and others just absolutely terrible. And you don't want surgery by a terrible surgeon, trust me. You'll get messed up. All right, done with L5S1. Our patient is asleep. We're not going to wake her up. We're going to let her sleep. And when she wakes up, when I'm done, then she'll be finished with her surgery, and the pain she came here with will be gone. I could say that confidently because I've done it literally 1,000 times, and I've done it with over 2,000 discs. And I know exactly what's going to happen. What are we listening to, a talk show?
No, we're in actually
All right, let's get our flow back in. Pressure. What is this, Delilah?
We're gonna put a Herniation on. 39.
So for those of you watching, I'm Dr. Ara Jukmajian if you just joined us. And this patient comes to us with 3 herniated discs in her back that are causing her symptoms. She actually has 5 herniated discs, but 2 of them are not causing any symptoms at all. Only the 3 are causing symptoms. So we're only fixing 3. That's something that's very important. Just because you have a herniated disc doesn't mean it needs to be fixed. I would say 95% of herniated discs don't need to be fixed because they're not causing any problems for people. We only do surgery on herniated discs that are causing problems. All right? There's no point in operating on a non-painful herniated disc, and like 95% of them are non-painful. So you would be surprised how many people walking around out there in the street or in the mall, you know, at work, that have herniated discs. Virtually everybody over the age of 40 has a herniated disc, but very few people have chronic pain from the herniated disc. Lots of people have back pain, but most back pain doesn't come from the herniated disc. It comes from the facet joints. Those are little joints. If you look at the dilator I just put in, it's passing the facet joint right now. If you look just below the tip of that pencil on the left there, there's a little mass of bone. That's the facet joint. That's the most common cause of back pain, but not in this patient. For this patient, it's actually the annular tear. She's fine. She's not even moving.
We have a question.
We have a question. You need to raise your volume. No, we're fine on the radio, even though the music sucks. Go ahead.
One of our viewers asks, what is the recovery time for a surgery like this?
What's the recovery time for a surgery like this? 1 hour. That's the recovery time. 1 hour. When can you go back to work? Tomorrow. As a matter of fact, I've had patients have this surgery and go back to work the same day in the evening. They just can't drive the same day. As long as somebody drives you to work, you can go back to work the same day. But most patients take a few days off of work, like 2 or 3 days off. But tomorrow, this patient could go back to work. I don't think she's working currently, but if she did, she can go back to work tomorrow. So it's a 1-day recovery. Pretty remarkable for back surgery. So I'm putting the tubular retractor over the dilator. We're treating L4-5 now. And I'm using the x-ray machine to kind of find where I'm at, right? And to guide my instruments in. I'm using a hammer to hammer it in, shot. I get a lot of comments from people saying, my God, you use a hammer. Like, how could you do that on somebody's spine? We use hammers all the time on the spine. You people just don't see it. The truth is, in orthopedics and neurosurgery, we use a lot of crazy instruments that are scary to look at, and you think, my God, that looks dangerous. It is dangerous. That's why we're highly trained surgeons. But the hammer in particular, is that my latest view? The hammer in particular is very important because it actually allows me to deliver a very precise amount of force. You know, as opposed to pushing with your hands, where you could, push too hard and the tissue gives away, and the next thing you know, you're sliding into the belly, poking around the intestines and all. You don't want that to ever happen. So, just for the record, I've done 1,000, more than 1,000 of these surgeries now, and we've never had a single complication. No infections, no nerve damage, no spinal fluid leak, no abdominal organ injury. The only thing that's ever happened is we have 1% of the patients will have a recurrent disc herniation. That means that they're going to go do something they shouldn't do after surgery usually, and they end up with a second herniation. Now, sometimes if you toss and turn a lot while you sleep, you can actually re-injure your disc during sleep. I've seen that happen once. So you have to be careful after surgery to protect the disc while it heals. They're very vulnerable. You know, when I do this disc repair, I'm actually cleaning up the annular tear and getting the herniation out, but the disc is still very vulnerable. It's very easy to re-injure it. And the longer you get away from the surgery, the further you get away from the surgery in terms of weeks and months, every day it heals a little bit more, every single day. So if you wait a year after the surgery, the disc is solidly healed, and you can do pretty much anything you want to do. No restrictions at all. So, but let it heal. I have some patients who are too aggressive with their activities right after surgery. They're feeling so good. They think they're back to normal, which they are feeling normal, but their disc is not by any means normal until it's completely healed. Then it's normal. So they make the mistake of judging their healing based on how they're feeling. Healing and feeling are not the same, okay? One's with an F, the other's with an H. And also the spelling is not the same, but long story short, don't confuse the two. You have to heal properly. Otherwise, you're not going to feel very good. So 1% of my surgery patients that have this Deuk laser disc repair end up re-injuring the disc again and needing another surgery. The way you can avoid that is by following my instructions very carefully. I am always available to my patients, so if they have a question about an activity or something, they're welcome to call me or my team, and we get back to them right away. So for those of you wondering, I'm a neurosurgeon, board certified, trained at literally one of the top training programs in the world, one of the top 3. How do I know that? Because my mentor at USC Med School before I went to residency was Dr. Marty Weiss. Marty Weiss was not just the chairman at USC in Los Angeles of neurosurgery, but he was also the chairman of the Residency Review Committee. And that's the Neurosurgery Residency Review Committee. So he basically was in charge of the committee of neurosurgeons that monitored every neurosurgery residency program in the United States and basically worldwide, because the United States sets the standard for training in the world. Sorry, England. I know you don't like to hear that, but it's true. So I was fortunate enough to be trained in one of the top 3 neurosurgery programs in the world. And if you went with Dr. Marty Weiss's opinion, I went to the best in the world. He thought the program at UF in Gainesville with Dr. Roten, the chairman, was the best in the world. So I trained at the best, but I never learned this surgery in my residency because they weren't performing it. This is something that was being performed primarily in Korea, South Korea to be specific. And it really had its origins in a hospital called Woodydal Hospital. And the president of Woody Doll Hospital at the time was Seng Ho Lee. Dr. Seng Ho Lee was a neurosurgeon who basically became, in Asia, the top endoscopic spine surgeon in all of Asia. And he would train other surgeons, including myself. And then I finished my training here in the States with Dr. Anthony Young, who was probably the mentor that I enjoyed the most and spent the most time with. He taught me a lot about this endoscopic surgery. But over time, I developed my own technique. It was different than everyone else's. And what I found is that my outcomes were also different. They were better than any of my mentors, by far. So I started to look at what I did differently, and I realized the biggest difference was I did an annular debridement, and they did not. They all performed discectomies. And the discectomy is important when you're decompressing something, but it's not so important when you're not decompressing. You need to clean the annulus up. So I took what they taught me, the technique, the basics, and I made an improvement on it. It's kind of like they taught me how to make a rifle, and I turned around and made the Gatling gun, which I know may be offensive to some people, but it's technologically it's more advanced. Functionally it's more advanced. It's heavier, but it has, I think, better results in many ways. Not that I'm a proponent of the use of guns, because I'm not. But you understand what I'm saying? I took something that existed and I made it a lot better. Just one small change. I mean, I made several changes, but I think most significant change was the debridement of the annulus. So here's the annular tear. You can see it in all its glory. It just looks all jacked up, right? You can see the fibers right here, kind of in the middle of the screen, where they used to connect with the other side. And just so you understand, the Deuk laser disc repair procedure, I actually go through the annular tear with the instrument. So I'm not actually doing any damage to the disc by going into the disc. I'm just passing through what's already torn, what's already damaged, which is perfect because I'm in exactly the right spot to repair it. So this is really an incredible surgery. Again, only available at Deuk Spine Institute here in Florida. So you can see the end plate right there of L3. That's like a little bone spur back there where I'm pointing at. I have a few blast marks in the bone, and this is the last of the tear right here. And I'm going to debride this. And when I'm done, the pain from this disc will be gone forever, unless she re-injures it. You have a question for us, Sean?
No others so far.
All right. Don't think I'm anti-gun, by the way, because I'm not. I'm very pro defending your home and your family from home invaders. But that's about it. I'm very much against war and death and murder. But I'm not an idiot, and if somebody comes to my home, well, let's just say they better bring an army. I read a story 2 weeks ago about an orthopedic surgeon who was killed in his home during a home invasion. As a matter of fact, it was on Thanksgiving Day. The home invaders showed up and killed, well, look at that herniation right there, folks. That's pretty amazing, isn't it? You see it wiggling out? Standby laser. That is exactly what I'm talking about. A piece of nucleus pulposus wedged in to the annular tear, causing inflammation. Anyway, the home invaders came in and basically killed the surgeon. Didn't have to. Right in front of his family and guests. I don't know. Maybe they were upset with the surgeon. They didn't say if it was a patient. They didn't talk about that. I mean, most of them just want money for drugs anyway. It's crazy what people will do to get drugs these days. They'll kill somebody over $20 to buy some heroin on the street. It's disgusting. Unfortunately, everyone has strayed so far. We're regressing socially, going back to the dark ages. Maybe we've just had it too good for too long. We've gotten soft. I don't know. All right, so we're just finishing up Deuk laser disc repair at L45. I apologize. Earlier I said that was the end plate of L3. It's actually the end plate of L4. And we're going to go to L34 next. So we're at the L45 disc. We've already completed L5S1. Can you turn the radio off? This music sucks so bad. I can't stand it. I'd have to be deaf to listen to this. I don't know why they play garbage on this channel. There's so much good rock and roll they could play. All right. If you couldn't tell, yes, I'm very opinionated. This is a good time if you have questions to ask them.
We have one.
Sure.
A viewer's wondering, other than rock and roll, what are some other genres of music that you enjoy?
Oh, that's a good question. Other than rock and roll, what are some other music that I enjoy? All right, just real quick, what we're seeing at about 11 o'clock is the nerve root, but it's covered with fat, which is good. Remember, I told you her foramen were wide open, and that's the normal appearance of a nerve. It's covered in fat and veins. But you can see the herniation's gone. It was right there, just underneath the nerve root. I do want to clean that up a little bit, Luis, right there. I like classical music, Baroque music. I like techno music, electronic music. You know, I like the 80s type music, U2, Duran Duran, all that stuff from the 80s where I grew up. The only music I don't like is rap and, country western. I know I'm going to offend some people, but you ask me to answer it and I'm going to answer it honestly. I just don't. I've tried and I just don't like it. But pretty much everything else, you know, some pop, but I'm not crazy about pop music. I really like mostly 80s and rock and roll. Yeah. Alrighty, so we've done the second disc at L45. We're getting ready to get into the third disc, which is actually the top one, and that is going to be the L34 disc. We've already done two. We did the L5S1, the L45, and now we're going to do the L34. For those of you who have been watching this wound carefully, you've noticed that we've only lost about 5 cc's of blood. 5 cc's, if you think about a drop of blood is about 20, a cc of blood is about 20 drops. So, you know, if we lost 5 cc's, we lost 100 drops of blood. It's really not much. You lose more in a nosebleed. So this surgery is pretty much bloodless surgery. I think the most I ever lost was really rare, but I lost 10 cc's, 10 mils, which is, you know, 200 drops of blood. But normally we lose under 5 milliliters of blood. All right, so we've got our last disc to do. You can see the guide wire is still in there. I mean, sorry, the needle and guide wire is still in there. And we're going to take the needle out under fluoroscopic supervision. And I'm going to leave the guide wire in. Remember, we only made one incision, one cut. One single cut to fix all 3 discs. Isn't that remarkable? Let's show our audience this cut. Can you see here?
Yes, we can.
Remarkable. 3 disc herniations, 1 cut. If you did traditional surgery, I lost the blue towel. If we did traditional surgery, the cut would be this long. Okay? Because you're doing 3 discs. And honestly, traditional surgery won't fix this problem. The microdiscectomy, laminectomy only fixes leg pain. And that's only when the nerve is being pinched. But if you have a leg pain or leg symptoms that are from inflammation from the herniated disc, the laminectomy is not going to fix that. The microdiscectomy is not going to fix that. That's why a lot of laminectomies and microdiscectomies fail. Because if you don't have a giant herniation compressing the nerve, there's no point in doing a microdiscectomy. And if you don't have severe foraminal stenosis, there's no point in doing a laminectomy. You know, symptomatic foraminal stenosis. You'd have to have neurogenic claudication, which is pain down your legs with walking and standing. So only the Deuk laser disc repair can fix back pain. Not laminectomy, not microdiscectomy. A fusion can fix the back pain, but not the decompressive procedures most of you are familiar with hearing about. All right, taking the guide wire out, still have the dilator, aiming at 45 degrees, shot. Here we go down the tear. Shot. Yep, good. Shot. Yes, all right. So we're into the disc. Again, L3-4. Now, for those of you who came late, let's show them the tube that we're doing the whole surgery through. You all see the tube?
We can.
Yeah. So I'll just show you this real quick. Can you watch the suction tube? Basically what I'm doing, folks, if you can see, this is the endoscope, camera, light source, irrigation. I'm basically putting this endoscope down, and look what happens. It pops out the end right there. You see that? And I'm doing the surgery way down here. Okay? So that's how endoscopic surgery is done. And this is spinal endoscopic surgery. So this is the most advanced spine surgery in the world done today. Obviously for degenerated discs, herniated discs. I'm not talking about tumor surgeries. I'm not talking about, reconstructive surgeries. I'm talking about for herniated discs, which is the vast majority of people's problems that have spine problems. They have herniated discs. Shot. As I do this, I don't want to advance the dilator. Shot. And I don't want the dilator coming back either towards me. I want to advance my tubular retractor over the dilator. Shot. Beautiful. So we'll be done in 10 minutes. Shot. Doctor. Just to give you a heads up. I'm sorry? Oh, Patel, yeah. Shot. Yeah, let Patel know we need him here in 10 minutes. All right, so that's looking pretty good there. And let's get the fluoro out, please. Any other questions from our audience?
Not at this time.
So today we have 3 of these surgeries. So if you need to stop at Walmart and get some popcorn, some soda, go ahead. We'll take a break for a little while, let you catch up on your snacks. And if you want to invite a friend over, this is one movie you won't get in trouble for watching. All right, let's get everything on. I need the scope on, camera on. And it's December, what? December 10th. I'm horrible with names and dates. December 10th, 2019. So if you're watching this surgery today at 9:23 Eastern Standard Time, you're watching it live. We stream our surgeries live for free over the internet around the world. Every single surgery that we do at Deuk Spine Institute, every single one, from beginning to end. We have nothing to hide. We want the world to see the right way to do surgery. That's really what it comes down to. If you can watch how surgery should be done, then you can demand that from your doctor. You can demand that you get the best care, just like we give at Deuk Spine Institute. You want the best for yourself and your family, you need to demand it, because the doctors aren't just going to give it to you. The insurance companies sure as hell aren't going to give it to you. And the hospitals aren't going to give it to you, but you got to demand it. Okay? When was the last time anyone just gave you anything? The least you have to do is ask for it and demand it. So, I can tell you there are so many bad spine surgeries being done all over the world. Probably, if I had to guess, 80% are really substandard, subpar. And I want you, the viewer, to recognize what's the best, right? Why do we have the Olympics on television every year? So you can see what the fastest runners look like. You can see their time. You can see what the best archers in the world, what they can do. You can see what the best in the world can do. That's why we watch the Olympics. That's why we watch professional sports. People are very fascinated with watching the best perform. Well, you're watching the best perform in spine surgery. Not trying to toot my own horn, but I really am. And I only say that because of our results are the best results in the world. You bring me another spine surgeon that has 0 complications in 13 years of doing the same surgery, okay, endoscopically on discs. You won't find one because there is none. You bring me another spine surgeon that has 95% relief of back pain or neck pain with this surgery. 95% relief of leg or arm pain. Just one. Bring me one. You'll never find one because it doesn't exist. And I'm not bragging. What I'm trying to do is impress upon you facts, because facts are important. Facts are truths. And for people to make decisions about their health care, their bodies, they need to know the facts. Right? Does anybody disagree with me about knowing the facts before you make a healthcare decision? Do you know what that's called? Luis?
No, sir.
Yes, you do. Don't say no. It's called informed consent. Okay? The whole purpose of informed consent is to know the facts before you make a decision about treatment or testing. Patients should always know the facts. They should know the truth before they decide. Okay? I'm a big believer in transparency. I'm a big believer in truthfulness. And a lot of doctors, a lot of hospitals hide the facts. Insurance companies are the worst. They lie to their beneficiaries. Oh yeah, we cover that. You're fully covered. Bullshit. Then when they actually need something done, it's not covered. So I don't mind a healthcare provider giving you shitty care. As long as they tell you up front you're going to get shitty care. As long as they're honest about it. As long as a surgeon will look you in the eye and tell you the truth. Okay, my patients, only about a third of them actually get any better from surgery that I do. Oh, really? Thanks. I'm glad you told me that. I'm not coming here. But they won't tell you that. Because if they told you that, they go out of business. And it would really suck to invest 30 years of your life to become a doctor, a surgeon, and then have to tell your patients that you suck at surgery and that you're more likely to hurt them than to help them. How many people are going to come to you? You see? That's the reality of the world. You won't hear it from too many people, but you'll hear it from me. Why? Because I told you I believe in informed consent. I believe in the truth getting out there. That's why we do these broadcasts. Do you see me broadcasting brain surgery? Huh? No. Why don't I broadcast brain surgery? Because I don't do it. No, simply put, because I'm not the best at brain surgery. I'm not going to broadcast brain surgery if I'm not able to teach somebody the right way to do brain surgery. Sure, I'm good at brain surgery, but I'm certainly not one of the best. Aneurysm surgery, same thing. Pediatric neurosurgery, same thing. You'll never see me broadcast doing a surgery that I don't think there's an educational value in me teaching somebody the right way to do it. We believe in broadcasting things that are of educational value. We want the public to learn, not just to be bored. This is an educational program, not a entertainment piece. If it was an entertainment piece, I would be doing singing, while I'm operating. I would do my best Pavarotti.
We have another question.
Yes.
This question was submitted by a user through the Duke Spine Institute app.
Sure.
He asks,
great.
I've had a prior spinal fusion C4 to L3 with Harrington rods inserted at age 11 and removed at age 17. Now I'm 31 and the vertebrae above and below the fusion have degenerated discs and facet disease, but injections aren't helping the pain. What are my options?
All right. Well, first of all, thank you for being brave enough to post that question. And it sounds like you've had an incredibly big spine surgery at some point early in your life. You most likely had something called idiopathic or childhood scoliosis. And that's probably why they fused your spine from C4 to L3. You developed what's called adjacent segment disease, is what it sounds like. I don't have any radiographic proof of it, but that's what I would most likely say is causing your symptoms. So you've basically developed symptoms and pain from the discs above and below your fusion. You've tried injections. They aren't working. Definitely surgery would be a very good option for you. What kind of surgery? I would need to see your films. But ideally, you'd want this surgery, the Deuk laser disc repair. It certainly is able to be done when patients develop adjacent segment disease where they're having symptoms of pain or radicular symptoms above or below their fusion. This would be the best option for you because it avoids any fusions. And by the way, the problem with fusing, and you may already know this, in a patient who already has instrumentation in, is a lot of times you have to remove that old instrumentation to be able to do the new fusion. And so removing the old instrumentation would mean taking out all the screws and rods from C4 to L3, which would be, that would be a really big undertaking. So my advice to you, number one, come to Duke Spine or submit your imaging. Let me evaluate it. I do that for free for anyone who wants me to. Or, we don't limit it. I literally will look at it personally myself as the founder of this company, and I will give you my honest opinion about what I think could be done. But whether you could do the Deuk laser disc repair or not doesn't matter, because I do spinal fusions as well, and we do them honestly better than pretty much anyone else. So we could do a spinal fusion if we needed to, or we could do this procedure, or we could do a combination of rhizotomies or discectomies or disc repairs. It just depends on what you need. What I need right now is another cup of coffee. So, Sean, will you make sure that a fresh pot's being brewed for me?
Can do.
All right. Well, hopefully that answers your question, whoever that was. But appreciate you posting your question. But definitely we can fix the problem. I just don't know which procedure it would require at this time. Any more questions?
None yet.
All right. Well, I'm going to digress a little bit because I want to update those of you who like to watch these surgeries and actually have an interest in the career of Arius Deuk Majan with respect to racing. As most of you know who've been following us, Arius is my son. He's a national champion driver of go-karts in the United States. He's a junior national champion last year. And he was signed by a talent agency at the age of 14, probably the youngest driver to ever sign a talent agency contract for driving in the United States. Anyway, he was recruited and signed by Independent Sports and Entertainment, ISE, and the director of motorsports is Susie Shriver. We signed in Chicago about 5 months ago. I got a call from Susie, and she said that they have a sponsor for Arius to go basically on his way up to Formula One, being we haven't had an American Formula One driver in many, many years. The last one was Scott Speed. Stand by. He didn't even finish 1 year, one season. He was on Red Bull and didn't last very long. Anyway, we don't know who the sponsor is yet, but she hasn't told us. I think they want to meet Arius first. It's a very big commitment financially for them, so I'm sure they want to be very careful. But there will basically be a movie made and a TV show made about Arius's climb up the motorsports world, hopefully to Formula One, and to be signed by a Formula One team, and to be a world champion someday, which I think he has the ability to be. So that's just our update. So hopefully the next time I talk about this, we'll know who the sponsor is, and they would have signed on for hopefully the rest of his career. All right, we're finished here with this annular tear. This is the last bit. I think we'll be done in about 5 minutes. This is pretty calcified. You see all that gold? That gold color is all calcium, bone spurs, calcification. And of course, this stuff takes a little longer to zap away with the laser. Excuse me. Fighting a bad cold. Just because I'm sick doesn't mean I get a free pass for the day. The boss said I had to come to work. Right, Luis? You know who the boss is. I've always considered my patients to be my boss, within reason, right? All right. Oh yeah, this is it right here. You can see the epidural fat right up there at 12, which is now at 2. Anyway, once the sponsorship is done, Arius is going to be traveling to Europe this summer. He'll be for 3 months in Belgium practicing with the best drivers in the world, the best go-kart drivers and some Formula One drivers in a special program being developed. I can't give you any more details, but let's just say that he's going to be in Belgium for the summer with a coach, a mechanic, competing with the top go-kart drivers in the world, the top 20, representing the United States. All of them competing for a seat in a very, very, very competitive top driving team. Where it's going to go, I have no idea, but I didn't expect it to go here either. So we'll see. Maybe the story continues. I hope. Any other questions from our audience?
We have one. A viewer asks, do you currently have someone in training to learn the surgery technique?
Do I currently have someone in training to learn this surgery technique? The answer is no, I don't. I do not have anyone in training. I've had a fellowship available for several years now through the San Francisco match program, but the position has gone unfilled all these years, which is very surprising. I guess nobody wants to live in Melbourne, Florida, where we launch rockets into space. Right, Luis?
Yeah.
Such a horrible place to live. It's like torture living here. I mean, you'd have to, if you wanted to come here and train, you'd have to live here, which means you'd have to give up living in the big city where all the important people are. You'd have to give up traffic. I mean, who wants to give up traffic, right? You'd have to give up smog and congestion. You'd have to breathe clean air, unfortunately. And you'd have, honestly, you'd have to live near the beach, which is just horrible. Nobody wants to live near the beach. You'd have to leave that concrete jungle, and you'd really be tortured at night because there'd be all this light coming from the stars that you'd be able to see at night. Stars and moon, which you can't see in the city. Thank God, right? I mean, who wants to see stars at night? Who wants to see the moon? Who wants fresh air? Who wants streets that don't have traffic? Nobody. Nobody in their right mind would ever want anything like that. Oh, and the cost of living here is so low. I mean, you might have to find other things to do with your money besides give it to the government and pay state income tax. So yeah, it's a pretty tough place to live in. You know, we've barely managed here. Right, Luis?
Yeah.
Being so close to the beach, you have to listen to the waves. You got to see dolphins swimming around in the surf. I mean, scary, scary creatures. I laugh most of the time at the world and the people in the world because they just don't make any sense to me, but that's okay. I still take good care of them. I gave up Los Angeles to be here. I look back at my family that I left there, and most of them moved out here. But the ones that stayed, they're pretty miserable. They are not having a good existence. So I'm very happy getting away from the big city, moving out into suburbia. We actually live near Orlando. Our practice here at Deuk Spine is just close to Orlando. We're less than an hour's drive to the airport, Orlando International Airport. A lot of our patients fly in to Orlando. But the people that live and work here really enjoy quality of life, and we don't have the big city shops, but I don't think the big cities are going to have standby laser. They're not going to have the big city shops anymore either because they're all closing down. Amazon's putting everybody out of business. So whether you, and I do buy from Amazon, but whether you live in the city or you live in the country, it's pretty much all the same. Let me get that one last piece right there. We're pretty much done here. So you can see from the surgery that I did clean up the annular tear, but there's a hole there, and really any heavy lifting, bending, twisting, on any kind of force on the disc would really push out another piece quite easily. So patients have to be really careful after the surgery to make sure that they don't overdo it. Really what it comes down to. Until they're healed all the way. All right, we're done. That was our last disc, the third disc. Sucking the water out.
Hey, Patel, is it work?
Yes.
Okay.
He came before to follow.
Cool.
Yeah, we're ready. We're done. So we're going to get Dr. Patel in here next, who's going to do a rhizotomy on the facet joints. It's kind of a combined procedure. The rhizotomy will treat facet pain. What I just did, what you watched, the Deuk laser disc repair, fixes disc pain, which is what this patient primarily has. But just to be sure, we do a rhizotomy to take care of any facet pain as well. All right, you got pressure there? You see the incision, everyone? It's as wide as my fingernail. Tiny, tiny, tiny. So, great job, everyone. Nice job with the anesthesia. Thank you. EBL is 5 mils. I'm going to head to the conference room in a few minutes, and I can answer any questions our audience has. So, if you've been watching the surgery, you want to make a comment or ask a question, type it up now, and I'll come over there and I'll answer it for you. Again, I'm Dr. Ara Deuk-Majan, CEO and founder. Deuk Spine Institute, located in the Space Coast of Florida. Many of you have already downloaded the Deuk Spine Institute app. It is available on Apple and Android. And the app is free, and it's probably going to be one of the best spine apps out there. So I recommend you download it. Also, join the Facebook page. It's called Spine Surgery Support Group. Spine Surgery Support Group. It's free. All of the stuff we do, we try to make everything free if we can. And this is a left RFA.
And left piriformis.
And the left RFA is what levels?
L3, 4, 4, 5.
L3 to S1. And left piriformis. She does have a little. Anyway, the spine surgery support group, we pretty much let everybody in. Don't try to come in there and advertise because I won't allow it. But if you have legitimate questions, you want to be part of the community, you want to be part of really the hottest spine support group there is, then join the spine surgery support group, because you have literally world-class interventional pain management, neurosurgery, thank you, answering questions in there. You're going to get the best answers possible. We're not trying to sell you, magnets to put on your skin. We're not trying to sell you creams and balms and stuff that doesn't work. We'll only give you the facts, the real truth, the real deal. All right, talk to you soon. Okay, Dr. Deuk Magent here with you, and for those of you who watched the whole surgery, we performed a Deuk laser disc repair, L34, L45, L5S1 through a left side approach. The patient had left leg symptoms, and if people have left leg symptoms, I go on the left side of the lower back. If they have right leg symptoms, I go on the right side. If they have both legs, but one is dramatically worse than the other, I go to the side where the symptoms are the worst for the lower back. On the neck, on the other hand, if we're doing a cervical disc herniation and the patient has neck pain and arm pain or arm symptoms like numbness, tingling, or weakness, then I'm going to go on the opposite side. That's my approach. So if it's right arm symptoms from a cervical disc herniation, I'll make the incision on the left side of the neck and vice versa, depending on the side of the symptoms. So this patient had a single incision. It was 7 millimeters. It's the width of a dime or less than a dime. And through that one little incision, we performed 3 disc surgeries. Pretty remarkable. There is no surgery in the world that has a smaller incision, and every other type of back surgery is much bigger incisions and usually in the midline. And those incisions usually also need bone to be removed from the spine in order to get to the disc, which we don't take the bone out of the spine. The main reason we do the surgery through the approach that we use from the side, which is the flank, is so that we don't have to remove any of the bone of the spine to get to the disc herniation. Whereas all other surgeries done on the spine, the surgeon has to remove the lamina and part of the facet joint, and that's going to weaken your spine where they did the surgery. By weakening the bony spine and the joint where they do the level they do the surgery, it's going to cause problems for the patient down the road. Now, this is a matter of opinion, and some surgeons would argue with me and say that no, that's not true, that people who have a microdiscectomy do fine, they don't have problems, but that's not true at all. 100% guaranteed that at least 1/3 of the patients, more likely a half, that have a microdiscectomy where bone is removed from their spine, which it always is with a microdiscectomy, those people are going to end up having either back pain, or they're going to have a recurrent disc herniation, or they're going to have radiculitis. But here's what the surgeons do. Patient has microdiscectomy for leg pain, right? And they have a huge herniation crushing the nerve. Surgeon does a laminotomy, facetectomy, microdiscectomy. They take out the herniation. Patient goes home in a day or two. And the patient comes back to the clinic saying, my back hurts. The surgeon says, well, go do some physical therapy. Take some muscle relaxers. The patient does that, then they come back again and they say, my back's still hurting. And the surgeon says, well, let's get another MRI. Everything looks good. Just, go see pain management. Then you ask the surgeon, hey, how did that patient do? Oh, they did perfect. Well, you did a microdiscectomy. You took out some of their bone, their lamina, their facet. That's going to destabilize the spine and make it weak. They're going to end up with problems like pain. Oh, no, that doesn't happen. Well, they have pain. No, but that's from something else. No, it's from your surgery, you dingbat. That's exactly what it's from. And so these surgeons, though, will never admit it. It's incredible. It's like asking in Star Wars, asking the evil emperor, are you evil? And he says, no, I'm not evil, I'm good. Those rebels are evil. Well, wait a second. Or asking an alcoholic who drinks a 12-pack of beer a day, are you an alcoholic? No, I'm not an alcoholic. I don't drink hard liquor. No, you are an alcoholic. You just don't realize it. So these spine surgeons, truly, most of them have no clue that they're actually creating more problems for patients because they just pass the patients off to the next guy, to the pain management doctor. And they say, oh yeah, pain after back surgeries, everyone gets it. No, they don't. No, they don't. That's where you're wrong. And that's what the public needs to know. The public needs to know the truth. The truth is that microdiscectomies, laminectomies are completely unnecessary 98% of the time. Now, there are going to be some people who have severe degenerative condition of the spine with huge bone spurs in their foramen and lateral recess. and they do need a laminectomy, but they also need a fusion, because what's going to happen is you're going to have to take that bony facet resection out so wide you're going to remove the entire facet joint, because what happens is there's a ligament in the foramen and the lateral recess, and as the discs degenerate in the patient over time, that ligament thickens and buckles into the foramen and pushes on the back of the nerve root in the foramen. And then you get this subsidence of the facet joint where the top of the inferior facet actually digs into the exiting nerve root under the pedicle above. And the only way to treat this horrible stenosis is to literally do what's called the Smith-Peterson osteotomy. And that's why I do that procedure on every one of my fusions. Because if you don't do a wide decompression in the foramen and lateral recess, you risk the patient waking up with leg pain that they didn't have before, or not getting rid of their leg symptoms that they had before. And that would be catastrophic, especially since it's a fixable problem. And now you fuse them with screws and rods and cages, and there's no way you're going to go back and do that afterwards. So I always do, on open back surgeries, a wide decompression with a Smith-Peterson osteotomy, not just to decompress the nerve root in the foramen and lateral recess, but also to allow correction of alignment to get the patient lordotic and straightened on the sagittal plane. So I hope I'm not talking above anybody's head, but what I'm talking about is how the old surgeries like microdiscectomy, which are still being done all over the world, are horrible because they actually ruin your spine where they do the surgery, and that weakens the spine and causes more problems like pain. So I'm really advocating for you, the public, to understand that you don't want microdiscectomies and laminectomy because they're old techniques that are basically barbaric. And they're creating more problems for you down the road. You want a transforaminal disc repair. That's what I did today. I'm not the only surgeon in the world that does endoscopic transforaminal surgery, but I'm one of the few that do. And there's probably 20 of us in the world that are any good. And in the United States, there's only maybe 2 of us. And the surgery that I do is an endoscopic transforaminal disc repair, but I do an annular debridement, which nobody else does, and that's why I can get rid of back pain. All right, so people all wonder, well, back pain is not something that's surgically curable. Yes, it is, as long as you repair the annular tear. The problem is nobody else knows how to do it but me, and that's because I discovered the procedure back in 2006. And so back then I realized the annular tear was really the majority of the problem, and it had to be debrided. Not just the hernia removed, but you had to repair the annular tear to fix the patient. So when I started doing that, I started getting basically perfect results, like 100% pain relief, 100% pain relief in virtually every patient. And I knew I was onto something, and that's why I published the results so other people would learn about it. And I've gone to all the big meetings for the American Association of Neurological Surgeons, Congress of Neurological Surgeons, ISAS, NAS. I've talked at these meetings on this Deuk laser disc repair, and unfortunately it just hasn't really made any impact on doctors. They don't care. They don't care about this technology. They're too busy putting in screws and rods and cages and artificial discs. They're all getting greased, getting money from these implant companies that are making billions of dollars putting this stuff in. So it's a really sick culture, and I do these broadcasts to make the public aware of what's happening to them. I'm kind of like Morpheus, in the Matrix. I'm making those of you that are in the system, you're completely oblivious to the truth. You don't know the truth, and I'm making you aware of the truth. The truth is ugly. It's nasty, and it's harmful to you. And that is that these implant companies and insurance companies basically have the same goal, which is to prevent you from being healed naturally with laser treatment. Now, I got to talk about this for a second, because I'm seeing all these laser spine stuff pop up everywhere. This laser stuff where they put the laser on your skin, on your back, that's going to help temporarily with some flow of blood and stuff, but that's not what we do here at Deuk Spine Institute. We do real endoscopic laser surgery. We cut your skin, we go into the disc and repair it. These transdermal laser treatments don't do that. So they may make you feel better for a while, if they even work, but they're not the same thing as what I'm doing. Okay? I've also heard of scamming places where patients go there, promised laser surgery, they show up and they're told, oh, your insurance won't cover it on the day of surgery. The day of surgery, they're being told their insurance won't cover it, and that they have to write a check or credit card payment for $10,000. That's not right. That's unethical. We at Deuk Spine don't do that. We bring our patients in. We figure out what you need done. If you need laser surgery, we tell you ahead of time. We tell you what it'll cost. And all that's done before your day of surgery, so you're aware of it. Because every insurance's coverage is different for different procedures. All right, I think we have a few questions. Am I right? So Sean's going to give us our first one.
Our first question is, how does DLDR differ from a foraminotomy?
All right, well, we have our first question. And it's a good one. How does Deuk laser disc repair, DLDR, differ from another surgery called the foraminotomy? Great question. So a foraminotomy is a procedure that's done surgically to open the neuroforamen. And specifically, you go into the foramen and you basically remove ligaments and bone spurs that are narrowing the foramen. So how is the Deuk laser disc repair different? Well, foraminotomy does absolutely nothing for the herniated disc, and a foraminotomy does nothing for the annular tear. And if you remember, the annular tear is the most important thing to fix with all disc herniations. The most important is to debride the annular tear. That has nothing to do with the foraminotomy because the annulus is not in the foramen. It's in the disc. The disc is not part of the foramen. It's next to the foramen, but not part of it. So a foraminotomy has nothing to do with an annular debridement. A foraminotomy can do one thing and one thing only, unpinch a nerve. And the nerve that's being pinched would have to be causing sciatic pain shooting down your leg to your calf or foot. If you don't have that, and you have something else like back pain, the foraminotomy will not help your back pain. Not one bit. Pinched nerves going down your legs, those nerves, they're called nerve roots. Pinching them doesn't cause back pain, ever. Ever. What causes back pain is the disc herniation. The disc herniation is not the same as a pinched nerve. A pinched nerve is with something that's actually pushing on your nerve root. Pinched nerves cause weakness in the legs, numbness in the legs, sciatic pain down the legs, tingling in the leg. That's it. And there are foramina in the neck as well. And if you get a pinched nerve in your neck, you can have arm symptoms, just like leg, with numbness, tingling, weakness, and pain down the arm. So foraminotomy is only done to unpinched nerves if a patient has just purely 100% leg symptoms without any back pain whatsoever, or without any neck pain whatsoever. So if all you have is sciatica without back pain, then a foraminotomy may be a good option, maybe, but I would never do it because there's better options, and the better option would be the Deuk laser disc repair. The Deuk laser disc repair, you can do a foraminotomy endoscopically. Well, I hope that answers the question. Here, let's go to the next one.
Our next question is, what is your opinion regarding endoscopic fusions like ET diff?
What is my opinion regarding endoscopic fusions? Well, look, here's my opinion. Anytime you can do a surgery that's less invasive, that gives the patient safer, better outcomes, I'm 100% behind it. So I have not yet seen an endoscopic fusion that gives patients better result than the Deuk laser disc repair. I have not. Otherwise, I'd do it. As a matter of fact, I'm the first surgeon in the United States to do an endoscopic fusion. And I did the endoscopic fusion back in 2006. And I'm not talking about a open endoscopic fusion. I'm talking about a transforaminal 7mm incision endoscopic fusion. And I can tell you that if you don't achieve your surgical goals with an endoscopic fusion, you're going to fail to give the patient the best surgery possible. So what are those goals? Well, if somebody has a herniated disc with back pain or neck pain, your goal is to debride the annular tear. Quite simply put, debride the annular tear. If you can do that and unpinch the nerve, if it needs to be unpinched, then that is the best result possible you're going to get for the patient if you do it endoscopically. And that's done without fusion. The only time you really need a fusion is if you have instability. And instability that needs a fusion, to be quite honest with you, is pretty rare. So I'll be perfectly honest with you, I don't see a need for endoscopic fusion. If you had to choose between open versus endoscopic, perhaps endoscopic would be better, but you have to achieve your surgical goal. If one of your surgical goals is to correct the alignment of the spine, aka to go from a abnormal angulation of the spine from a collapsed disc, and you want to put the spine back into a curve, you can't necessarily do that endoscopically. Okay, you have to remove the facet joint to do that. So it's really more complicated than a simple question and answer, but I'm going to be perfectly honest, I don't do endoscopic fusions because you don't need to. There's really no benefit. If there was, I'd do them because I did them back in 2006. And if you're interested to know how I did them in 2006, it was pretty incredible. I used something called the transfacet pedicle screw, which is percutaneous. It's basically a screw that goes into the pedicle but through the facet joint. So it goes into the inferior facet first of the segment you want to, it goes into the inferior facet of the superior vertebral body of the segment that you're going to fuse. And then it goes into the pedicle of the body below. And I did those along with inner body cage and inner body fusion, all done transforaminal along with a discectomy. And I'm going to tell you right now that those patients that had the fusion did not do any better than the patients who didn't have a fusion, who had a simpler, less expensive surgery. So I'm not trying to say that a endoscopic fusion is bad. It just depends on the indication and the need, what you're trying to achieve surgically for the patient in order to get rid of the patient's back pain, neck pain, and arm and leg symptoms. So as long as you can achieve the goal endoscopically of surgery, then that's what you should do over an open surgery. Okay? Any other questions? All right, that's our last question. Since I'm fighting a cold, I'm going to end the broadcast here. We'll be back in about 20 minutes with the next surgery.